So welcome to the module on arterial disease. Within this module, we're going to cover a little bit about the anatomy of arteries, as well as some of the physiology behind it. After that, we'll look at the two principal disease processes involved in peripheral artery disease, being atherosclerosis and hypertension. And then we'll focus more on peripheral arterial disease itself and look at some of the areas within the body where we commonly find arterial disease, such as the carotid arteries and the arteries of the leg. We'll go on to talk about complications that can occur because of peripheral arterial disease, so gangrene and necrosis, as well as the different kinds of amputations that can be done and some of the acute ischemic events that can occur and how we manage those. By this stage of study, you should be quite comfortable that arteries are composed of three different layers. We have our tunica intima with a squamous epithelial lining, allowing for smooth laminar flow through arteries. We have our tunica media that contains all of our vascular smooth muscle cells, and these can contract and relax in response to different signaling molecules such as nitric oxide. And we have our tunica adventitia, which is connective tissue lying around the arteries that helps to anchor it into nearby tissues. Between these layers, we also have different elastic sheets or the elastic lamina that help the artery to contract and relax in response to the blood pressure and blood flowing through it. And the image on the right is also showing that we have some perforating vessels, the vasa vasorum, that supply arteries themselves directly. And we see these in larger arteries like the aorta. As arteries get smaller and smaller and subdivide, we can also get branching of arterioles, so smaller arteries that supply smaller areas in the body, and their structure is generally quite similar. Blood pressure is an important thing to be aware of in terms of arterial physiology, and although it's not physiologically correct to think so, this image quite nicely shows that if we consider blood pressure as being composed of the cardiac output and the systemic vascular resistance, then we can understand arterial pressure a little bit easier. So cardiac output itself is composed of stroke volume, so the amount of output from the heart in one cardiac cycle, and the heart rate over 1 minute. And this can be impaired in heart failure or advanced heart disease. Whereas our total peripheral resistance or our systemic vascular resistance is composed of our mean arterial pressure and the difference between that and our central venous pressure divided by our cardiac output. So essentially, if we have heart disease, venous insufficiency, or advanced arterial disease, then we see changes in our total peripheral resistance. The image on the right-hand side quite nicely shows us that as our cardiac output and our systemic vascular resistance change in response to nervous inputs from the medulla, we get a change in arterial pressure that feeds back to our baroreceptors, or our pressure sensors that are located within our aortic arch and also our carotid body. Wall tension is also something important to be aware of. So we have this law on the left-hand side, Laplace's law, which essentially tells us that wall tension increases when we increase the pressure and radius within a cylinder. And the way that our arteries are adapted to function is that they have an increased wall thickness, meaning that we're able to maintain this wall tension within acceptable parameters. And this image on the right-hand side is showing us that dependent on the amount of arterial tone, so vasoconstriction or vasodilation within our peripheral arteries, we can adjust our systemic pressure. And a really good example of this is when we're talking about perfusion of kidneys. So whether we have vasodilation or vasoconstriction in our afferent or efferent glomerular arterioles, affecting back on our systemic blood pressure. And that's really all as much physiology as you need to know about arteries and blood pressure. It's just important to have those things in mind when we talk about the contributing pathological processes, one of which is atherosclerosis, and the other of which is hypertension. So we understand atherosclerosis as being the build-up and accumulation of fatty plaques within arteries. And this initially starts with a small amount of damage to the arterial lining and then the accumulation of lipids within that, initially as fatty streaks, that then attract and accumulate macrophages that become enveloped with lipid and they become these foam cells. Lipid further accumulates and we get these intermediate lesions that then become more complicated and develop as atheromas. So when we talk about atheromas and atheromatous plaques, they can either be soft plaques or they can be hard plaques, depending on how long they've been present in the arterial lining and what medications a person is taking. So soft plaques or soft atheromas are more likely to rupture. And the problem with this is that when they rupture, they can create emboli that move into small, tiny distal arteries and create focal areas of ischemia. And depending where that is in the body, we get different clinical presentations. As atheromas develop and become more complicated and become fibroatheromas, they become a lot harder and essentially a lot more stable. So they're less likely to rupture and cause an ischemic event with an emboli. However, they are still contributing to arterial disease, and they're reducing down the diameter of that artery and increasing the pressure within that arterial system. What can happen is that if you have a complicated lesion that has mixed atheromatous and fibroatheromatous areas, you can get these little caps on these atheromas that can rupture and accumulate a thrombus. So as well as the embolic event of a part of the plaque breaking off and going into distal circulation, you'll also get a thrombus formation on top of the atheromatous plaque, which can lead to complete occlusion of the artery there. And the main thing that predisposes someone to developing atherosclerosis is having a high lipid content in the blood. And that can be affected by genetic components, so we're all aware of familial hypercholesterolemia, but also lifestyle factors. A sedentary lifestyle, a high-fat diet, all add to high lipid concentrations in the blood that predispose this atheroma formation. And until these become extremely advanced, complicated and severe, they tend to be clinically silent, or people are very asymptomatic with them. Hypertension is the other thing to be aware of, something that we see quite a lot in clinical situations. Hypertension is defined as blood pressure greater than 140/90, and we tend to take that on a 24-hour blood pressure reading just to exclude any white coat syndrome. And the risk factors for hypertension tend to overlap with cardiovascular risk factors and also with the general risk factors that we look at in an arteriopathic patient. So increased weight, any diabetes, a sedentary lifestyle, smoking is another big one, alcohol consumption linking in with high sugar and an unhealthy diet, and also high sodium. There are more non-modifiable risk factors, so as people get older, as they get generalized atherosclerosis, that increases their blood pressure. A family history of high blood pressure is quite significant, and also ethnicity. We tend to see that Afro-Caribbean or African-American ethnicities develop hypertension much earlier and much more severely. And we can group hypertension itself into two different characteristics, so idiopathic, which tends to be more due to modifiable and non-modifiable risk factors, and then arteriosclerosis, which again is due to high lipid exposure and poor lifestyle choices. Our secondary hypertension tends to occur as a result of renal disease or renal artery stenosis or endocrine abnormalities, which are outside of the scope of this lecture. So atherosclerosis is a systemic process, so it doesn't happen in one focal area of the body. But as it becomes advanced in certain areas, we tend to get different clinical manifestations. So the most common site, or the biggest accumulation that we find in the body of atherosclerosis, tends to be in the iliofemoral arteries, so the iliac vessels and the vessels leading into the legs. If we have atherosclerosis in our carotid arteries, that can lead to TIAs and strokes. If we have it in our coronary arteries, that can lead to myocardial infarctions and coronary artery disease. Within the abdominal aorta, it can lead to mesenteric disease, it can predispose aneurysm formation. Within renal arteries, it can reduce renal function and create renal artery stenosis, which can limit the kind of medications we can give patients. And if we get it in our femoral arteries, then we can end up with claudication type symptoms. It can severely affect people's ability to walk and function in life. In the most severe cases in the limbs, if we have atherosclerosis that progresses to the point where there is so minimal blood flow through them, then you can start to see changes within the skin, and you get ulcer formation and death of tissue. So within the arteriopathic patient, or one that is predisposed to developing arterial disease, we look at a lot of these modifiable and non-modifiable risk factors that, again, as we just said, link over into cardiovascular risk factors and hypertension risk factors. One of the key things in managing these patients is identifying these modifiable risk factors and attempting to reduce them or better manage them as much as we can do. So focusing now on peripheral artery disease of the lower limb, we're quite happy that it's caused by atherosclerosis, and it's this interaction between high blood pressure and fatty deposits and this development of atherosclerosis that leads to peripheral artery disease. So in the short term, we have some damage and inflammation to blood vessels, and this can create the opportunity for atherosclerotic plaques to develop and propagate hypertension. As these vessels become further and further narrowed, we start to get symptoms of claudication. So claudication itself occurs when we have narrowing of blood vessels and the amount of blood that gets through becomes smaller and smaller, so much so that it's unable to fulfill the metabolic demands of surrounding muscles. In situations where metabolic demand increases, like exercise or walking uphill, then these muscle groups are forced to undergo anaerobic respiration because they're not receiving adequate blood flow to undergo aerobic respiration. It's the buildup of lactic acid within these muscle groups at this time that creates these claudicant type symptoms. And we tend to use claudication, or the distance at which claudicant symptoms occur, as a way to monitor the severity of arterial disease. So some patients with early disease may be able to walk 100 meters before getting claudicant symptoms, but people with very severe and well-established arterial disease may only be able to walk about 10 or 15. And that's a good clinical indicator of how severe someone's arterial disease is. So long-term, as this peripheral arterial disease progresses, we start to see that these patients become deconditioned. So over a long period of time, as the muscle within their limbs is receiving less and less blood, there is an accumulation of waste products and the degeneration of muscles and structures within the limbs. So as well as atrophy, you may also see the breakdown of skin. You may also see necrosis and gangrene starting to set in as these limbs become poorer and poorer perfused and start to die. So the main symptom alongside intermittent claudication is that they may get leg pain, particularly at night. And one way that we can look at this clinically is with the ankle brachial pressure index that we'll discuss on the next slide, as well as using ultrasounds. So ultrasound is a very good tool because it allows us to see essentially inside blood vessels, so we can assess how stenosed or how narrowed they are from looking at the ultrasound. The duplex component also means that we're adding a Doppler effect onto the ultrasound. So as well as seeing how stenosed or narrowed down these vessels are, we're also getting a good idea of the actual amount of blood flow that's going through these arteries. This gives us a relatively high detailed imaging that can be used to further assess how severe this arterial disease is across all of the arteries of the lower limb. And in terms of managing these patients, as I've emphasized multiple times already, conservative approach is always the initial approach that we try and use. So try and manage somebody's comorbidities and try and manage someone's risk factors as much as we can do. So smoking cessation is a really big one. Encourage exercise, adjust diet, reduce alcohol consumption are all paramount in managing arterial disease. Pharmacological management tends to be managing the comorbidities, so managing high blood pressure, any heart disease, diabetes. Commencing people on statins is also really important to reduce any lipidemia. If both of these approaches prove ineffective and claudication or ischemia is starting to develop, then we can look at some surgical approaches, and we'll go more in depth on those in a few slides' time, as well as some of the complications that can occur. We'll cover necrosis and gangrene and amputations in this lecture. Osteomyelitis is essentially an infection that occurs through ulcers that progresses in towards bones. So typically we see this in feet as a complication of arterial or diabetic foot ulcers, and that's just treated with antibiotics. And myocardial infarctions you should all be aware of from your cardiology placements at university. So the ankle brachial pressure index is something that you see quite uniquely in vascular surgery. And what it essentially involves is taking the blood pressure in the arm and the blood pressure in the ankle and dividing one by the other. And essentially what it implies is that the difference in blood pressure in the leg is due to the amount of stenosis or arterial disease created by atherosclerosis within the lower limb. So as the ankle brachial pressure index gets lower and lower, it's a sign of progressive arterial disease. And you can see in the table, as the number progresses down towards what should be 0.3, we go from no arterial disease down towards critical limb ischemia, where surgical intervention is indicated as soon as possible. In the situation where we get an ankle brachial pressure index greater than 1.2 or 1.3, this is not to imply that there's actually, an excessively healthy person that has excessively good arteries in their legs. It's actually almost implying the opposite. What we find in this situation is that the reason that the ABPI is so elevated is because these persons' arteries are calcified, so they've become quite hardened and incompressible. This tends to be something we see in patients that have diabetes. These patients uniquely get calcific deposits in their arteries, meaning that they're quite difficult to compress with a blood pressure cuff, and we get this paradoxically high ABPI reading. The only times that you shouldn't really do an ABPI are essentially if you are at risk of dislodging something that's in the leg. So if someone has a DVT, if they have severe ischemia because there's a risk of causing tissue damage, or if they have an infection in the leg, so cellulitis, largely because it would just be cruel and quite painful to compress somebody's leg. So we've already covered claudication in a little bit of depth. We've gone through the fact that it's restricted blood flow due to arterial disease causing pain. And we assess patients with their claudication distance. Symptoms are quite progressive and we manage them medically and conservatively as much as we can do. And eventually it does progress to critical limb ischemia. The way that we initially manage these patients, alongside risk factor modification, we like to give them antiplatelets. It's been shown in quite a lot of studies that starting clopidogrel 75 milligrams once a day is a very effective strategy in helping to slow down the progression of arterial disease. And this flowchart shows us quite nicely that along with antiplatelet therapy, exercise, risk factor modification, and symptom relief, which all forms a part of this best medical management and conservative therapy, those are our first line defense against progressing claudication before we attempt revascularization. And this slide essentially summarizes everything we've just spoken about in a nice succinct way, so you can refer back to this later on if you'd like to. So in the situation of critical limb ischemia, where the ABPI is less than 0.3, and we start to see severe changes in the legs where they become quite cold, where the pulses are no longer present, where there may be tissue breakdown and evidence of necrosis or gangrene, we like to assess these patients for surgical management to revascularize them. As well as continuing to manage their risk factors and pushing antiplatelets, we assess them for the best surgical option to revascularize their limb. Failing successful revascularization or failing any indication for revascularization if the limb is deteriorated too far, then revascularization may be unsuccessful or unattemptable, and an amputation may be a better option. There are a number of different surgical interventions that can be done to revascularize limbs, and we'll go through them all individually, but it's just important to make aware first that how we decide on which procedure to use is all dependent on the type of arterial disease and in what way it's progressed. So arterial disease can either be quite focal in particular areas, and it can create quite tight stenoses, or it can be quite diffuse or spread out across a wider area in an artery. So although arteriosclerosis is a general systemic thing that occurs all over the body, in certain areas it can occur more than others. It's the essential gist of that. So in patients that have quite small, tight stenoses, we can sometimes do a balloon angioplasty. So under radiological guidance, a balloon catheter will be inserted into the vascular system, and the balloon will be inflated at the point of the tightest stenosis, just to see if they can essentially dilate the artery out with the balloon and increase blood flow that way. These are generally quite successful. They are a good way to minimally invasively revascularize someone's limb, but they can only be done where there is a really focal, short, tight stenosis. If there's any diffuse disease, And doing a balloon dilation would be unsuccessful and quite difficult because there wouldn't be this small area that you can dilate. So in areas where we have a tight stenosis, but it's essentially a little bit longer than the ability of a balloon catheter to dilate it, what we can do in the situation of a femoral stenosis is a femoral endarterectomy. So what we do with the femoral endarterectomy is make a small cut down to the femoral artery in the groin, and then we open the artery up, and where this plaque has accumulated, we essentially scoop it all out. So remove the inner lining of the artery. And this is quite a good way to restore blood flow when there is that relatively small focus of atherosclerosis. But the risk that we have with it is that when you're playing about and scooping things out of arteries, if you're not careful, then you can cause a little bit of internal damage and cause a smaller portion of the plaque to embolize and be pushed further down into the arterial system, and you could iatrogenically cause a limb ischemia. And that is one of the acknowledged complications and risks with this procedure. But as with any surgery, there are risks and complications, but if the benefits outweigh the risks, it's something that should be considered. Another thing to note is that when we close up these arteries, we tend to use a small vascular patch just to close the artery over. If you imagine with this longitudinal incision, if you were to suture the edges together and they were everted, so pushed out, you'd actually be creating an artificial narrowing in the arterial lumen. So what we do is use a little vascular patch, an artificial synthetic graft that we can sew the natural arterial edges onto, just to maintain the normal patency of the arterial lumen. The next surgical intervention that we can consider is an arterial bypass, one of the most common ones being a femoral popliteal bypass. So we can either use an artificial or a patient's own vein as a graft in order to bypass around an area of advanced diffuse disease. So the theory behind this is similar to a coronary artery graft. So if we have a blocked coronary artery or a narrow coronary artery, we can use a graft to bypass around it. And this is the same principle in the leg. So the natural graft that we like to use is a long saphenous vein or a great saphenous vein graft from the medial side of the leg. But if this is an unsuitable vein, if it's quite diseased or varicosed, or if it's already been used in heart surgery, we may have to use an artificial graft. There are a few options with artificial grafts, but the main thing to be aware of is that in the post-operative period, because they're not the body's own tissue, they can be recognised as being non-self. And what this means is that when the blood enters it, if these patients are not appropriately medicated on antiplatelets, then these grafts can clot off, and then you'll have a reduction of blood flow into the limb again. And that's one of the risks with that procedure. So this image is just nicely demonstrating that on the left-hand side, where we have the black mark in the vascular tree, we have this diffuse elongated area of blockage. And it would be unfeasible to use a balloon catheter to dilate all of that blockage, and it would also be very difficult to scoop out the entire inner lining of that long segment. So what we can do is put a little graft, which in this case it looks like they've used a vein graft, where you can see that blue line, just to go from proximal to distal and allow blood flow to go around the blockage back to the lower limb to reperfuse it with blood. Generally, they tend to be anastomosed from the femoral artery down towards either the popliteal artery or the anterior tibial artery, whichever one is more suitable in this particular patient. As with any surgical procedure, these patients should be consented beforehand, nil by mouth, advised to stop smoking, and they will need to start antiplatelets, particularly in the post-operative period, to make sure that this new graft does not clot off. Alongside the risk of ischemia and blockage of the graft, there are also general surgical risks of any bleeding or wound infection. Now, a As arterial disease becomes particularly advanced and we approach the level of critical ischemia, we encounter these situations of necrosis and gangrene. These terms are often used very interchangeably, but there is a difference between the two of them. And necrosis is defined as dying tissue and uncontrolled death at a cellular level, unregulated cell death. And it occurs in tissue that is non-viable due to long-term ischemia and lack of blood flow. But ultimately, necrosis is at a stage where there is a potential reversibility to it. So if we reperfuse tissue, what can happen is that where there are areas of necrotic patches or small blackened areas on feet or legs, by reperfusing the tissue, then these cells can rejuvenate themselves. So we can replace the necrotic cells with healthy active cells and reverse that process. However, if this situation progresses further and further and we end up with complete ischemia of portions of tissue, then we end up in the situation where we have gangrene, which is dead tissue, as opposed to necrosis, which is dying tissue. So gangrene comes in a few different varieties, and we have some lovely pictures for you on the next slide. So we can either have dry gangrene, wet gangrene, which implies infection, or we can have gaseous gangrene, which implies infection with different kinds of bacteria, more likely anaerobes. Where we have dry gangrene, if it happens in smaller digits like toes, we can enter this interesting scenario where you have a well-demarcated line of healthy tissue and then some dry gangrenous tissue distally. In these situations, the body has its own mechanism of dealing with this gangrenous tissue, and we can get auto-amputation. So if you spend some time in a vascular clinic or in a vascular ward, you may see some patients with some dark, blackened, dry toes. And the temptation would be to amputate these manually in surgery. However, because of the lack of blood flow to that particular area, it's quite likely that these wounds would heal very poorly and may get infected. So it's better to adopt a conservative approach and let the body handle its own amputation process. And these pictures just help to nicely show the different things that we've just spoken about. So on the top left, we have some necrotic patches on a foot. We can see that distal to the necrotic patches, we still have some living tissue, and proximally we have some more living tissue, but there are these areas of underperfused ischemic tissue that has become necrotic. On the bottom left, we can see this dry gangrene in a foot, and as I was talking about previously, you can see that you have this line of living tissue demarcating where we have some still viable tissue and then completely dead gangrenous tissue. So in that situation, those toes may auto-amputate, and then in the top right and bottom right, we have this situation of infected gangrene, where we have wet gangrene, which, as the name implies, is dead tissue that is become very wet, very sloughy, and oftentimes quite smelly. On the bottom right, we have gaseous gangrene, which is generally identified on X-ray, where you can see there is this mottled appearance to the radiograph underneath the bones of the foot, where there are gassy deposits from the bacteria that have been dividing there. So depending on the extent of any gangrene or necrosis, if the body's not able to auto-amputate or we can see infection, then there may be an indication for amputation. The other indication for amputation would be if we have an ischemic limb acutely that has been acutely ischemic for so long that the limb is non-viable. And we have different types of amputations that we can consider. So we can do toe amputations to remove toes. We can do midfoot amputations, as you can see in the bottom right. And then we progress on to things like a below knee amputation, above knee amputation, and then a hind quarter amputation, which would be an amputation of the entire leg up to the pelvis. So the main risks with an amputation, depending on the level that it's been done at, are that the wound may not heal properly if there is advanced arterial disease, and there may be a necessitation for further amputation if there's any further infection or a lack of healing in the wound. But one thing to consider, depending on the type of amputation, is that these patients will often require extensive rehabilitation. If they're particularly old and frail, then they may not do well with a prosthetic, so they'll need to be rehabbed in a wheelchair, and their care needs will change dramatically. And in these cases, we find that amputation will directly lead to immobility. And with immobility, you're predisposed to picking up further infections and your life expectancy is reduced. So the decision to amputate is a very big example of a risk-benefit scenario and how to best manage a patient's conditions. So moving away from peripheral artery disease of the legs, we'll now talk about carotid artery disease, or carotid artery stenosis. So if you think back to your anatomy classes, you'll know that within the carotid arteries we have our internal and external carotid arteries. Our external carotid arteries supplying everything essentially in the face, and our internal carotid arteries supplying everything in the brain, anastomosing with the vertebral arteries to create the circle of Willis, and we have our cerebral and cerebellar arteries branching off of that. So that collateral circulation of 4 arteries feeding into the brain is quite important, because if any one of those 4 vessels becomes quite diseased or stenosed, then there's still blood flow reaching the brain. However, with significant carotid artery stenosis, we can get the development of transient ischemic attacks, and if there is any rupture or embolization of the atherosclerotic plaques within these stenoses, then we can have the event of a stroke. So symptoms and signs of advanced carotid artery disease essentially are those of a TIA, so any focal neurological deficit that lasts less than 24 hours. Particularly as amaurosis fugax is one that's described quite well clinically of a shutter essentially coming down on one side of a patient's vision and then declining as an embolic event resolves itself. One thing you may hear on clinical examination is a cervical bruit. So a bruit is essentially turbulent blood flow that we're hearing through an artery created by a stenosis. And it's an auscultatable thing. If you put your stethoscope over a patient's carotid artery and get them to hold their breath, you may hear a cervical bruit. The main investigation that we do in these patients is a duplex ultrasound. So this ultrasound that also gives us an idea of blood flow within the arteries. And from that, we can assess how stenosed these carotid arteries are. And in terms of managing them, similarly with arterial disease in the legs, we try to use pharmacotherapy first. And if the level of stenosis is particularly significant, then we can consider surgery. And the cutoff that we tend to use for that is 70%. So the indications for a duplex scan essentially mirror everything we've just discussed. So any patient that has any neurological symptoms indicative of a stroke or TIA, anyone with a cervical bruit, a pulsatile neck mass that may be indicative of a carotid aneurysm, and evaluating any patients that have syncope, seizures or dizziness that may be as a result of reduced blood flow to the brain because of this focal atherosclerosis. So in the acute setting, if their carotid arteries are stenosed by less than 70%, something that we find out from the duplex scan, then these patients will be managed conservatively with antiplatelets and cardiovascular risk reduction. If their carotid arteries are stenosed greater than 70%, then alongside antiplatelet therapy and risk reduction, they will be eligible for surgery to remove the inner lining of their carotid arteries or to have a stent fitted. So this would be a carotid endarterectomy, very similar to the femoral endarterectomy that we mentioned earlier. The only time that this changes is if a patient has already had a stroke, so they've had symptoms. In this case, we lower the threshold to 50% for when we operate. And this image on the left just demonstrates what a carotid endarterectomy is in the same way that we did with the femoral endarterectomy. So we can see that this yellowness within the internal carotid artery is the plaque and the fatty deposit creating a narrowing. And we open the carotid artery and remove the plaque and sew it back over to reperfuse and increase blood flow to the brain. And this can be done with general anaesthetic, or it can be done under a local anaesthetic. The main indicator for doing things under local or general tend to be surgical preference, but the biggest advantage of doing things under local is that you can communicate with the patient and you can get them to form some basic motor tasks to essentially double check that you're not reducing blood flow to the brain to a point where they're getting any hypoxic ischemic brain injury. So moving on to acute ischemic events now. These are caused by an acute lack of blood flow to tissue, and they're usually as a consequence of an embolic event that either involves a thrombus or atherosclerotic plaque. Really common sites of embolism tend to create medical emergencies. So if we have emboli coming from the carotid arteries, then we get cerebral and cerebellar strokes. Within the coronary arteries, if this happens, we get myocardial infarctions. And within the lower limb arteries, we get ischemic limbs. And within the mesenteric vessels, so the superior and inferior mesenteric arteries that run from the abdominal aorta, we get mesenteric ischemia, or ischemia to the gut. The biggest risk factor in this in the acute setting tends to be atrial fibrillation. So the ability of the atria to inadequately contract predisposes blood to sit and pool within the atria. And one of the prime things for clot development is hemostasis. So if these patients are inadequately anticoagulated or the atrial fibrillation has gone undiagnosed, then they will have clot formation within their left atrium that will be ejected into their systemic circulation. And this clot will continue to travel in the arterial circuit until it blocks off an artery that is too big to enter. And that could be any one of the arteries listed previously. So focusing on acute limb ischemia, the key symptoms we tend to look for are the 6 Ps. So a limb that is pale, painful, has no pulses, is unable to move and has no sensation, and is extremely cold. In these situations, you need to try and get as clear a history as you can to understand the onset. You need to assess the limb for any viability. So a limb that is white or a limb that has some capillary refill is a good prognostic sign. However, in a limb that has all 6 of the 6 Ps and has fixed mottling is a very poor sign that this limb is non-viable. These limbs require urgent surgical intervention to revascularize them with an embolectomy, or they may need to be amputated. In the acute setting, while awaiting surgery, what can be done is that these patients can be put on intravenous unfractioned heparin. So the heparin will prevent further clot formation, but it will also allow blood flow to continue through areas where the clot may not have completely obstructed the artery in its entirety. And that's essentially what this flow chart is telling us here. Alongside analgesia, which I forgot to mention. Analgesia is very important in these patients that are screaming in pain because their leg is dying. Another place that we can get acute ischemia is in the mesenteric vessels. And this is something that does come up quite commonly in exams, and if you ever work in A&E, it's something that you will see. And it's essentially a blockage of artery supply in the gastrointestinal tract, that superior and inferior mesenteric arteries that we mentioned earlier. And there's a typical triad that people present with. So they may come in with a fever and some raised white cells, have generalized abdominal pain, and they may have bloody stools and profuse diarrhea. And when you look at these patients closely, you'll find that they have quite a high raised lactate because they have a lot of ongoing ischemia, and they have a raised white cell count as a response to this ongoing ischemia. So mesenteric ischemia can either be acute, chronic, or acute on chronic. Acute ischemia tends to be due to an acute embolic event like we mentioned with atrial fibrillation and clot embolization. Chronic mesenteric ischemia can almost be thought of as claudication within the gut. So if we have atherosclerosis developing within our mesenteric vessels, when blood flow to those areas is increased after you've just eaten a meal, you may find that these patients get intermittent pain in their abdomen. And this will get worse and worse as these arteries become further and further stenosed. And then what these patients may get is a small embolic event, so an atherosclerotic plaque rupture or a small clot going into their mesenteric vessels that causes a complete blockage on top of an already narrowed vessel. And these patients can be assessed either with duplex imaging if they're quite slender, or with a CT angiogram, which is an investigation we do quite commonly to assess vascular trees. So essentially a little bit of intravenous contrast injected into the arteries that shows up the vasculature of the body. And this is quite a good way of detecting any blockages or narrowings. And the way that we manage mesenteric ischemia is dependent on the extent of it. So on top of revascularizing the gut, whether that's through an embolectomy or a bypass, there may also be the necessity to resect a portion of bowel if the ischemia has progressed to the point where we have completely dead bowel. So that covers generally most situations where arterial disease presents acutely or requires surgical intervention. And I can't emphasize and underpin enough that understanding the anatomy and the physiology behind atherosclerosis and hypertension is crucial in understanding peripheral arterial disease and where it presents in the body and why the complications occur in the way that they do. And it's absolutely paramount to gain radical control of these up front by trying to get on top of those modifiable risk factors and manage the non-modifiable risk factors as best as you can medically. With radical medical management and communicating the risks effectively to patients, you can attempt to slow down or halt the progression of their peripheral artery disease so that they won't require further surgery later on as the claudication distance worsens and their limbs start to become ischemic and necrotic. Those are some of the references that we've used for this lecture, and this is the biggest lecture of the entire unit with quite a lot going on. I'd recommend looking at some of these lectures and doing a little bit of research in your own time, particularly with vascular surgery, because we talk about things working systemically in a lot of different areas of the body. Reviewing the anatomy is always quite good to put these things into context.